A cardiac clearance is less about giving a green light and more about risk stratification and optimization. Here is a roadmap for evaluating patients before they head to the operating room in a simplified and easy to remember form. Before diving into tests, determine if the surgery is even a candidate for a workup. Is it an emergency surgery? If life or limb is at stake, the patient goes to the operating room. Your job shifts to post-op management and intra-op monitoring. Is it low risk? Procedures like cataracts, plastic surgery or superficial biopsies have a less than 1% risk of major adverse cardiac events. No further testing is usually required. Identify the red flags. Use revised cardiac risk index. 1 point for each. Ischemic heart disease, history of myocardial infarction, positive stress test or angina. Congestive heart failure, history of congestive heart failure, paroxysmal nocturnal dyspnea or S3 gallop. Cerebrovascular disease, history of transient ischemic attack or stroke. Diabetes mellitus, requiring insulin. Renal insufficiency, serum creatinine more than 2 mg per deciliter. High risk surgery, intraperitoneal, intrathoracic or suprainguinal vascular. The scorecard, 0 to 1 points, low risk. 2 or more points, elevated risk. Proceed to functional capacity assessment. Can the patient's heart handle a stress test in real life? We measure this in metabolic equivalence, METs. Can they climb 2 flights of stairs or walk up a hill without stopping? That is more than 4 METs. If METs more than or equal to 4, proceed to surgery. If METs less than 4 are unknown, this is where you consider further testing like stress test if it will change management. Here are a few suggestions for investigations. ECG, baseline for patients with non-coronary artery disease, arrhythmia or structural heart disease unless it's a low risk surgery. Echocardiogram, if there is a new or worsening dyspnea or a clinical suspicion of moderate to severe valvular disease. Example, a new grade 3 systolic murmur. Stress test for patients with elevated risk and poor or unknown functional capacity, especially if the results will change the plan. Example, lead to revascularization. BNP, emerging as a strong predictor of perioperative MACE, but not yet a must-have for every patient. Beta blockers, do not start them the morning of surgery. There is some evidence that it increases stroke risk. If they are already on them, continue them. Statins, continue them. If they are undergoing vascular surgery, starting them early is beneficial. ACE inhibitors and ARBs, generally held 24 hours prior to surgery to avoid intraoperative hypotension. Dual antiplatelet therapy. This is the tricky one. Consult cardiology if a stent was placed within the last 6 to 12 months. Here is a summary for decision making. Low risk surgery, proceed to operating room. Elevated risk plus METs more than 4, proceed to operating room but optimize medications. Elevated risk plus METs less than 4, consider stress test, cardiology consult. Unstable angina or decompensated congestive heart failure, cancel elective surgery, treat first.